Welcome to Dr. Ziegler Weighs In. I'm Zachary Ziegler, professor of exercise physiology and fellow of the American College of Sports Medicine. I've authored 2 books on weight loss and published dozens of research articles. I'm here to cut through the noise and give you evidence-based insights you can actually use. Now let's dive into the science. All right, welcome to episode 3. Thank you for still being here and listening. Let's start with a little news brief on what's coming out in the sciences about weight loss. It's interesting, the one I pulled for today, it's about semaglutide. Well, it's comparing trizepatide to semaglutide, and it kind of goes along with what we've been saying this whole time, that trizepatide better than semaglutide for weight loss, and that's what prior studies have been showing. Also, though, that the side effects are probably a little bit higher with trizepatide, the side effects being gastrointestinal events, which we're going to get into today anyways, and so that's what's coming out there. All right, let's get into part 3 of this GLP-1 mini series. I'm gonna title this one "The Reality Check: Side Effects, Costs, Long-Term Concerns." There's always risk. I always try to take the point, okay, what is the evidence saying? And I'm going to stick with that. So far, what have we highlighted? We've highlighted this drug. It honestly has changed the obesity medication landscape. It is effective. It has helped a lot of people achieve the weight loss goals that they have set for themselves. Are there risks to this? I want to start by discussing a little bit about these drugs in children. It's one thing to say, okay, you're an adult, here's this drug, and it's going to help you lose weight or whatever, and here's some risks and concerns. It's another thing, at least in my opinion, to give them to children. We don't know a lot about the effects of long-term effects of these drugs in children. I will tell you, though, that most position stands and recommendations do recommend that these children can use it. Here, I'm going to read this position statement. The consensus recommendation suggests that obesity, weight loss, pharmacotherapy, and this paper that what they're talking about is really the semaglutide type drugs, can be provided to children aged 8 to 11 in combination with healthy behavior and lifestyle. So they are now starting to give them to children. I wish I had a lot of data to review with you to say, okay, this is what we know long-term. I really don't. There's been some studies, yes, with semaglutide, liraglutide, these GLP-1s. What do we see? Same stuff as adults: nausea, diarrhea, vomiting, constipation, pain in the abdomen has been reported, headache, fatigue, dizziness, abdominal distension, hypoglycemia. And so there are these side effects that are reported. Most of the time, they're reported for the first few weeks, but that is an area of concern. As we learn more about these drugs in children, I'll try to bring that literature to the forefront to see kind of what we're getting ourselves into. But more on that later, maybe. Let's move to adults, though. Okay, one of the biggest concerns with these drugs is, as far as side effects, is the massive amounts of lean body tissue that is lost. It would be wonderful if someone lost 20 pounds, regardless of the way they lose it, diet, exercise, medication, and all of that was fat. That's not the reality, though. And this is important because nobody has ever said, oh, I want to lose 10 pounds of carb. I want to lose 5 pounds of bone. I want to lose 2 pounds of muscle. We just say we want to lose weight. Really, though, we want to lose fat. And I know that's a no duh, but we don't say it enough, and that's important to understand. Let me read some of the outcomes of some of the research on how much lean body mass is actually lost in some of these GLP-1 studies. Now, to make sure we're on the same page, lean body mass, we're talking about muscle and bone primarily. So the first study which is the most kind of the craziest outcome, 45% of the weight lost in a study looking at semaglutide, 45% of the weight lost was lean body mass. almost half of the weight that an individual loses based off that study was muscle and bone. Now, not all of the studies show that. Another study looking at semaglutide found 43% of weight lost was lean mass. A study looking at trizepatide found 26% of the weight that was lost was lean body mass. And so they're not all up into that 40s. But regardless, whether it's 25%, 45%, a lot of the weight loss is lean mass. Why does this matter? When we look at risk of, let's talk about health. When we look at risk of early mortality based off of someone's BMI status, especially as we age, individuals in the underweight group by far do the worse. So when we look at people above the age of 65, 70, above that age, when you're underweight, you are dying much sooner than someone in the obese group. And the reasoning behind that is this wasting effect, right? You're losing muscle, you're losing bone. It is a problem. And I think we don't hit this enough. So yeah, we lose a lot of lean mass. Most of the time in these studies, people are not incorporating exercise. Exercise can help with this to some degree. And so we're losing a lot of lean mass. It's a problem, a big problem. So does this drug, though, does it provoke more lean mass than, say, other lean mass loss, that is, say, than other weight loss type things? So, meaning, let's take diet. Do you lose more muscle when you're taking a GLP-1 compared to if you were just on a weight loss diet or, say, bariatric surgery? The answer is no. The slope of lean body mass loss is about the same. But here's the thing. Let's say you lose 10% of whatever of your weight that you lost is lean mass. Well, if you lose 50 pounds versus 30 pounds, then you lost more lean body mass when you lost 50 pounds. And so that's why it's much more problematic. From a long-term perspective, each kilogram of muscle mass that you lose reduces resting metabolic rate by 13 calories a day. So long-term, it becomes problematic, right? And so this needs to be identified. Now, I want to be fair here. Again, what is the science? Not all how we measure lean mass is problematic. This is what I mean. When we say, okay, you lost 20 pounds, and let's say that the researcher said, well, 10 pounds of that is lean body mass, muscle and bone. You want to ask the question, how did we measure that? Most of the time we measure that, it's through a technique we call a DEXA scan. And really what that scan gives you is the volume that you have. So let's take your quadricep or whatever. The DEXA will tell you the volume that is contained in that quadricep. Well, inside that quadricep, and we're going to assume that that's all muscle, but that's not true, actually. Inside that quadricep, we do have fat droplets. Everybody does. Now, people who are more obese obviously have more. When you lose weight and lose fat, a lot of those fat droplets get removed from within the muscle. And so the muscle shrinks. And so then we do these tests with the DEXA scan and we say, oh, your muscle shrunk. Well, in that situation, the muscle shrunk because you reduced intramuscular fat droplets, not necessarily because you lost all that muscle. And so what some researchers are finding is they're looking at what they're called muscle fat infiltration and the quality of the muscle. And they're finding that after taking these GLPs, that the quality of muscle actually goes up. Now, that doesn't mean that they're not losing any muscle or any bone. They are. But maybe it's not as big as the numbers suggest that they are. So it's not all doom and gloom. So that is something to note there. But one of the other issues, so we have the issues of losing lean body mass. One of the other issues is this is an expensive drug. Not all insurance companies will provide this medication for weight loss. Lots of them will want to ensure that you have maybe type 2 diabetes or some other comorbid condition before they say, okay, we're going to allow you to have this. And so you're paying out of pocket. This drug's about $1,300 a month, maybe $16,000 a year. That's a lot of money for the average person. Because of that, 38% of people stop taking these GLPs after 3 months. If you go out to a year, 50% of people aren't taking them. Well, you need to understand these drugs don't fix long-term what made you obese. Meaning, remember the way that they work, they send a signal to the brain to decrease appetite. We talked about this idea of food noise. That's probably what contributed to your weight, right? That maybe overeating, over snacking, that kind of thing. The drug doesn't rewire that pathway. It just kind of blocks it. Well, so if you stop taking the drug, then of course that food noise comes back and weight regain is probably an issue. When you listen to makers of these medications, I remember the first time I started kind of learning about this. This is before the GLPs became a big thing. I was at a conference and there were some scientists. Yes, they were funded by the pharmaceutical industry that put forth the medication. But to sit there and listen to them, they said, this drug, you're intended to take this forever. Completely straight face. They just said, no, that's the way it will work for. If you take it forever, it'll work forever. If you get off it, it's not going to work anymore. And so that is something that people need to realize when they're taking this drug. It isn't like, and I hear this all the time, well, I'm just going to take this drug and then fill in the blank. I'm going to take this drug for 6 months, 3 months, and then I'm going to get off and I'm just going to maintain my weight loss. I call total nonsense to that. The lifestyle and behavior choices that got you to where you were before you took that drug, why do you think you won't revert back to those behaviors? The strongest predictor of future behavior is past behavior. And so it really is intended to take for your whole life. And if not, you gain most of the weight back. A couple studies that highlighted this. One study found that switching to a placebo after 20 weeks of semaglutide resulted in weight regain of 7%. So they regained 7% of their weight after they went on to this placebo. But the group that stayed on the semaglutide lost 8%. Another study found that during a 1-year off treatment period of 6 to 8 weeks, 2/3, so meaning they were on semaglutide, then they switched to an off period, 2/3 of the weight that they lost came back. So the efficacy of these drugs really seem to be determined by the ability to continue to take them, or you're going to gain your weight back. And that is a huge problem. Meaning this is the issue with any weight loss thing that we've looked at, this idea of weight regain. It's the same with the medications unless you continue to keep taking them. Now, some researchers have said, well, let's add exercise to these drugs. Can that help? Those of you listening may be thinking, well, no, duh, you should be adding exercise. But the reality is, if you look at the numbers, the average person who's trying to lose weight is not trying to lose weight with the help of exercise. Last year, now this is average numbers, 8% of Americans achieved physical activity guidelines. Now, just in case someone's texting or checking my statistics, that's if you measure this objectively. Meaning there's a lot of surveys that people will give out and say, hey, how active were you? That's a subjective survey. I don't buy any of that. If you give those same people devices, we call them accelerometers, there are Fitbits and Apple Watches, all those kind of things. You give those same people these objective measures of physical activity, and we see a huge disconnect between what they say they did and what they actually did. So 8 to 9% of people, that's it, achieve physical activity guidelines. But if you look last year, 50% of women and 35% of men were actively trying to lose weight. So 50% of women were actively trying to lose weight. Only 8 to 9% were achieving the physical activity guidelines. The vast majority of those women, and men are the same, it's just the weight loss numbers aren't as high. The vast majority of those men and women are trying to achieve weight loss without needing to add exercise to it. This is really, I'm kind of getting on a tangent, but I think this is really important to bring up, especially when we're talking about side effects. Most people, when you ask them, why do you want to lose weight? Often an answer that I get, especially when we get into a little bit older populations. Younger populations seems to be, very aesthetic. But older population, a lot of times they'll say things, well, I want to be healthier. I call bullcrap on that. Don't get me wrong. They may say that, well, I want to be healthier. But the reality is they want to look different. And there's nothing wrong with that. I have no problem with that. But we need to be honest with each other. You want to change the way you look. Dieting in and of itself is not a healthy process. It isn't. We'll go over in this podcast the science of dieting. It is not. You just want to look different. And the reason I'm saying that is we go back to this idea of how much lean body mass you lose. Let's take a lady. Let's just make up, someone says 75 years old, 60 years old, whatever. And she says, I want to lose weight to be healthier. So she loses 50, 60 pounds. 30 pounds, 20 to 30 pounds is lean body tissue. She's now extremely osteoporotic to where a fall is going to break something. 25% of women who break their hip die the following year because of the complications. Women's risk of hip fracture is higher than their combined risk of breast, ovarian cancer combined. So again, just be honest on why you're saying you want to lose weight. I had a girl in my office, and she was dieting for an aesthetic competition. I think it was, I don't know, a figure competition, something like that. And she'd sometimes pop in and ask some questions. And she said, so she's been dieting. She says, I just don't feel good. And I looked at her and I said, why in the world did you think you would feel good? When we cut calories and we push our body beyond homeostasis, the body, from a biological standpoint, says it's sick, so it fights back against it. These drugs seem to help a little bit in that biological pushback by blocking some of these appetite pathways that usually cause people to fail in a weight loss program. But they do come with side effects. And it's important for you to understand these side effects. So, adding exercise to these drugs, in my mind, if you don't do that, you are a fool. And maybe that's not nice, but I don't care. I don't understand it. If you say you're actually doing this to be healthier and not adding exercise, I don't understand why you would say that. It makes no sense to me. Now, researchers have looked and said, well, if we add exercise, can we maintain muscle mass to a greater extent than just taking the drug by itself? Well, the results of one study suggest yes, which again shouldn't surprise you. First thing that they said is, well, what about weight regain? Remember, everybody regains their weight. Well, the semaglutide, I shouldn't say that. It actually was liraglutide. It's the GLP-1. The GLP-1 group in this particular study gained 9% of their weight back. So meaning they went on this weight loss program with the drug, and then they said, okay, now we're done on the drug. They gained, not 9%, sorry, 9 kilograms back, which is about 21, 22 pounds. The group that continued exercising, though, after they took the drug, only gained 3.5 kilograms back. So they gained some weight back, but not nearly as much. When you look at the change in fat percentage of gaining fat back, the group that took the GLP-1 gained more fat back. The group that added exercise didn't gain nearly as much of fat back. These same researchers said, well, what about bone? Because again, we're losing bone in these studies. Well, the group that added exercise didn't lose nearly as much bone. There's a law called Wolff's Law. Wolff's Law, in essence, says that bone is a lot like skeletal muscle in the sense if we stress it, it adapts and grows stronger. Well, if we add exercise during this weight loss period and we're stressing the bone in a healthy way through exercise, you're not going to lose as much, and that's a benefit. So if you're listening and you're taking this drug, and I'm not here to say you shouldn't, from a weight loss standpoint, I think there's benefits to take this drug. But you must be adding exercise. And resistance training really is what should be added. Resistance training is going to maintain muscle mass, it's going to maintain bone. Now, let's get into some of the rare long term side effects, but you do need to be aware of them. There is, let me read from this case report. So it's a case study on one subject. There was a 60-year-old female. She had type 2 diabetes. She was taking a GLP-1 for 2 years, and she was found to have a lump in her neck. They found that it was thyroid cancer that according to this case report, they felt like was linked to GLP-1s. Well, it used to be, I guess the older school of thought was that we don't have any GLP receptors on our thyroid. In animal models, animals do have GLP receptors in their thyroid. So when we release GLP-1s, they need to interact with the receptor. And when it does that in animal models, it does cause thyroid growth and can lead to thyroid cancer. This has been shown in animal models. But again, the thought was, well, humans really don't have GLP-1 receptors on their thyroid. Well, there's a study by Gear et al. That showed, yes, we do have expression of GLP-1 receptors in our thyroids, and it could increase risk of cancer. Now, when we say this, nowhere am I saying that risk is super high, but to note, there is some evidence that long-term use could increase risk of thyroid cancer. We then go to pancreatitis. There is a lot of data showing an association is not causation, between GLP-1 use and acute pancreatitis. And so there's data out there to suggest, hey, maybe you'll be careful there. Gallbladder, this is probably where the evidence is the highest. I'm reading from a review paper, a meta-analysis of randomized clinical trials. And so this is pretty good evidence. What did they find? This systematic review and meta-analysis of 76 randomized clinical trials did find that use of GLP-1s was associated with increased risk of gallbladder diseases, especially when used for higher doses and for longer durations. Remember, what's the duration that is recommended by the pharmaceutical companies? Well, forever. And so that's something to be concerned about. But I do want to bring up something positive here. I have heard a lot of students have brought this up. I've heard this in the media, and there's no evidence for it. But I've heard people say, well, okay, this drug blocks this pathway of appetite. Therefore, now that's true. This next part is just make-believe. Therefore, it's probably diminishing the ability of people to feel good feelings. That's not meaning then they're suggesting it could lead to mental health problems. There's not good data for that. And actually, when you look at the papers that look at mental health outcomes in people who take GLP-1s, their mental health gets a lot better. I'm looking at one paper here. Again, it's a review. It's a meta-analysis looking at the effects of GLP-1s on depression. And what they find, our findings suggest that GLP-1s induced significant reduction in the depression rating scales compared to control treatments. Now, that shouldn't be surprising. If you change your body size, your body image, maybe you feel better about yourself and it can help. Regardless of the mechanism, though, it's not increasing risk of depression. Let me share a story, and then we're going to end. There was a couple so I served as a bishop for my church for a while. The role of a bishop is kind of like a pastor or a minister. You try to make sure that everybody in your congregation is doing well. There was this couple in my congregation. I'll make their name up. I won't use their real name, and I'll call it John and Beth. And both of them were morbidly obese. Beth, the wife, was confined to a bed in their living room. John, the husband, took care of her, but it was really difficult because his health was so bad. One day I received a call from Beth, and I think I was coming home from work. And Beth says, Bishop, that's what we call ourselves in our church, Bishop, John fell in the back. Now remember, she can't get up. And she says, John fell in the back and he's not getting up and he's not calling. He won't respond. At first I said, well, I don't know why you're calling me. Call 911. And so I said, I'll come over, but call 911. So I get there, and the ambulance was there. They had broken in because she couldn't open the door, dragged him out. Now he's probably 5 foot nothing. He's a really short guy, weighed at least 350. And this image is etched in my mind of them giving chest compressions on a gentleman this big who was already dead, but they were doing their due diligence. He died. She, because he was no longer there to take care of him, was then sent to this home. And I remember going to visit her, and I said, Beth, how are you doing? We're talking, and the ultimate objective of her being there is help her lose weight. And I said, so what are they having you do for weight loss? And I still remember that she was so excited. She said, I walked to the end of the hall and back today. And she was so excited. And I want to be her champion. And so, of course, I said, that's an amazing accomplishment. But in my mind, I thought, that's going to do nothing for your weight loss. Nothing. I say this because there are some of you listening that may be similar to some of my students and others that are out there that look at semaglutide and these drugs as if, oh, people are cheating and it doesn't count and all these things. I don't know why you say that. One, we want to support people. But two, if I go to this example that I just brought up of Beth and John, telling them just to cut some calories out, that's not good enough. They need a drastic solution. And maybe this could have been something that would have helped them. And so I hope this mini series has opened up, not to say, again, it's not risk-free. We went through some of the side effects. There's always a risk here. But under right circumstances, maybe for the right person, that these can be a benefit to them. If you have questions about any of these drugs, feel free to reach out, leave comments and those kind of things. Please leave a rating, keep watching, tell your friends, and I look forward to episode 4 next week.